First question would be, is the U.S. healthcare system a good deal for consumers? Are we getting our money's worth? And there's really kind of a mixed message here. And that is, we, of course, spend way more as a percentage of our GDP than the other industrialized countries around the world on healthcare. We spend about twice as much of our GDP on healthcare as other modern industrialized countries. These are, modern, sophisticated countries in Europe and Japan, et cetera. The other way to look at it is how much we spend per person, which is the left-right axis. So we spend a lot more per person, about 2 to 3 times more per person on healthcare. But our life expectancy, which I would argue is a fairly important indicator of health, is below average. And so there's a real perspective of, do we have an efficient system? Do we get our money's worth? Do we get the outcomes we seek? It's also interesting from a perspective of total health outcomes. Some of our measures are frankly, near the bottom in the world. We're second to worst among the OECD countries. Those are the industrialized modern countries in things like diabetes, infant mortality. So these are the sorts of things, the graphics, the data that folks in DC were looking at 5, 6, 7 years ago. Of course, the same data they were looking at in the early 90s, the same data they were looking at in Nixon's administration, same data that they were looking at after World War II when health reform was attempted multiple times. So then we get to the Affordable Care Act, which, believe me, there is enough political talk today. I'm not going to engage on that. But this was, of course, inherently a political response to a set of issues. It's highly, highly imperfect. And frankly, a lot of what we see happening across the country with health systems and payers and physician employment in some ways was really accelerated by the Affordable Care Act. So I'm not here to comment on whether it was a good bill or a bad bill, but I'll tell you a few of the trends that we see really accelerating because of the Affordable Care Act. One result that I would argue is a good thing is more people are insured. That was one of the core intents of the bill. So if you look at just the percent of uninsured Americans, indeed it has dropped subsequent to the bill being passed. We see this in our surgery centers, so we have roughly 200 surgery centers around the country. About 1.5% of our volume today comes from exchange products, and we'd estimate about half of that are previously uninsured patients. So about 75 basis points of our volume now are previously uninsured patients. I hope you're seeing what we're seeing is the vast majority of that volume is coming through at normal commercial rates. We had some trepidation regarding with these exchange-insured patients, be it Medicare rates or, heaven forbid, Medicaid rates, and what we're seeing is they're mostly at commercial rates. So we have more insured Americans, more people with health care coverage. That, of course, is one of the goals of the bill. A second result of the bill, and I think either Tom or Luke made this comment, which was an increase in consolidation, and we see this across multiple facets of healthcare. I'm sure you see the same thing, and we'll talk about this a little bit later. But we see, of course, consolidation among the largest for-profit and not-for-profit health systems. There's a real desire to bulk up. We, of course, see this also in local communities where regional or community-based health systems are acquiring, and really the standalone hospitals of 10, 20 years ago are going by the wayside. We also see that, of course, in physician employment. No news here that physician employment, especially of primary care and then in some markets of surgical specialties, really accelerated after the ACA. Interestingly, though, we see in a number of markets, we'll talk about some of the structures later, where that pendulum is halting, and frankly, we've engaged in a number of relationships where employed surgeons are coming out of employment if we can set up the right circumstances. And I would say a lot of this employment was not done out of a love for, I really desperately want to be employed. That was my desire when I was in medical school and my perfect fate. It was really driven by economics. And the question is, are we going to see over the next 5 or 10 years scenarios where the economics reverse and health plans and employers care enough about total cost that they're willing to make it worth physicians' while to come out of employment relationships? And frankly, we see some of those scenarios occurring, and we're helping to facilitate them. So the macro trend is employment, but I think there are some real signs that this trend is not going to continue forever, and in many cases can and will reverse. And then, of course, with health plans, it's beyond obvious today that health plans are getting larger and larger. The recent announcement of Aetna merging or acquiring with Aetna with Humana, and then Anthem with Cigna is just further evidence of health plans increasing in size. And I've been asked, is that a good or bad thing? I'll tell you, it really depends on your relationship with them. In some markets where we have a tight relationship, a very strategic relationship with the health plan, them getting bigger is actually a good thing for us. I know that sounds counterintuitive, but we'll talk a little bit later. The pressure on health plans now to bend the cost curve can involve incentivizing exactly what we do every day in this room and setting up payment structures that facilitate more care occurring in surgery centers. So there's a colorable argument that this can be a good thing, depending on our relationship. Third result is more value-based contracts. And of course, the whole headline was ACOs, and we've seen this growth in the number of ACOs. I'd say a lot of these ACOs look really good on paper, and they look good in a headline. And the reality is they're fairly thin when you get underneath them. And we've also seen some big name original ACO backers like Dartmouth Hitchcock in New Hampshire actually pull out. And so whenever I see a headline about ACOs, I scratch my head a little bit and do a little bit of a skeptical double take as to what's really underneath, and are these really here to stay. That said, there are some that are substantial and real. So here in Chicago, I think we have the largest ACO in the country, and it's backed by the Advocate Health System, which has a series of hospitals, but also 2,500 physicians and an IPA structure and medical group. Advocate's actually gone to the degree of having 80% of its revenue now in risk-based contracts, very little of it full capitation, most of it in a gain share. And what's interesting is with Advocate, we're actually beginning to build surgery centers or acquire them with the explicit purpose of pulling cases out of Advocate facilities, hospital facilities, into surgery centers. So there are some examples where if the ACO or the risk-based contract is real, if a material amount of the economics for a medical group or a health system are driven by risk-based contracts, you can see the behavior change. But you have to be careful. In a lot of cases, the ACO that has been announced or there's a press release is fairly small, a very, very minor part of the economics for a health system or for a group. In parallel with these three things, we see a fourth trend, and that's the rise of private exchanges, not really driven by the ACA per se, but really driven by the inflation in medical costs and employers seeking to contain those costs. So today there are about 13 million Americans buying health insurance through a private exchange. And if you're not familiar, basically the structure is the company gives their employee a set number of dollars and then allows that employee to go on to a private exchange and select a health plan that suits their needs. It's another form of shifting risk, frankly, to the employee from the employer. But 13 million is a significant number. One of the biggest conveners of private exchanges is Aon right here in Chicago, and they have nearly 1 million members or employees buying health insurance through their private exchanges. One of their biggest employer customers is Walgreens that has 160,000 of their employees buying off the Aon exchange. And so we see a tremendous amount of growth in the exchange products. These make terrific strategic partners for us. I'll tell you the amount of focus around how can you reduce cost for my product and how can we select a network of lower cost providers. Their incentive is very high. And you'll note on the left that the majority of these exchange products are inherently a narrow network design. So they are selecting providers or in many cases just saying you can go to anyone except these highest cost providers. And so we see these as a positive force. So those are some of the big trends that we see coming out of the ACA. 5-6 years ago, I would have spent the majority of my time talking to health system executives, and you heard a lot of that discussion with Luke and Tom and Morgan, and that certainly is a trend and a continuing trend, the health system partnership. One thing I'll talk a little bit more about in the next 20-25 minutes is the payer's lens and a renewed excitement on behalf of payers around what we do. And I'm going to share a little bit as to why in a moment. And I know many of you are saying, yeah, where have they been? This is 30 or 40 years. We've been sitting on a good story. But part of the cumulative realization is to control healthcare costs, there really isn't any set of strategies that doesn't involve optimizing surgery, because surgery is 30% of every dollar spent on healthcare in this country, 30%. And so as we've spent time with Blue Cross plans, United, we spent time with ACOs like Advocate here in Chicago, or time with the Aons of the world and private exchanges, the data is fairly consistent, which is in a commercially insured population, so that's all of us in this the room, so we're excluding seniors or Medicare or Medicaid plans, but for commercially insured lives, surgery is about 30% of a total per member per month cost of $300. And that's a national average. Some states like New York are going to be higher, other states are lower, but 300 is a good proxy. So surgery is a huge deal. And if you want to create a better healthcare system, you'd better address surgery. As we spend more time about what levers can they pull, the obvious one, and I know I'm preaching to the choir here, is site of service. Get more surgeries done in surgery centers. Pretty simple. And you save 50 cents on the dollar, and that's a big deal when the dollar here is 30% of the total cost of healthcare. A second lever is really what happens after the surgery. For a total joint replacement, there's often $5,000 or $6,000, maybe $7,000 of post-surgical institutional usage on average if you have a total joint in a hospital. So the post-surgical part of the spend is really important. And then thirdly, of course, the supplies and devices. There's a lot of attention on how we payers gain control of these costs. So, surgery is a big part of the spend. It's a big part of what health plans, risk-based entities, private exchanges are really trying to figure out. How do we crack this code? How do we make meaningful progress? The good news, of course, is we have a phenomenal value proposition. So let me just take a moment to brag on behalf of all of you in this room who are part of our industry. People talk about the triple aim of healthcare: improve the patient experience, improve quality, reduce cost. Of course, we sit at the heart of this. Just our own data in SCA, our Net Promoter Score, which is a very commonly used metric. Thousands of companies around the world use Net Promoter Score. Our patients have a 96 Net Promoter Score, meaningfully higher than even Apple or Costco. So patients love our setting of care. Our quality outcomes are terrific. This is our largest volume total joint center. Our CEO is here in the audience, Michael Patterson, but our infection rate is less than half of what infection rate is in a hospital environment for something like total joints. You know this. Quality outcomes terrific in our facilities. And then our cost savings are incredibly significant. And if you look at this through the lens of a health plan or an ACO, the impact we can have on total medical spend if we shift the shiftable cases into a surgery center can add up to 5%, maybe even 10% of total medical cost for a health plan. So there are very few levers available if you manage a population that can create as big an impact as shifting surgery and optimizing surgery. So that's great news. On the flip side, you've also heard in the last 45 minutes here with Luke and Tom and Morgan and Scott, we have a changing market too. So we're sitting on the precipice, I think, of some great opportunity, but we also have to face some realities. Our market's under significant pressure in many ways. And for those of you who are part of the industry 10, 20 years ago, and I'm new to it, I joined just shy of 8 years ago, but really the 80s and 90s, the early 2000s, a huge boom of building and de novos, lots of unaligned surgeons that we got hooked into surgery centers, drove a lot of growth. Really 5, 6 years ago, and since then, the industry growth has slowed meaningfully. And really, that's a result of a handful of things. There are more physicians that are already in a surgery center, so a smaller unaddressed market. There are a lot of pressures on independent practices. And in fact, one of the things I found most amazing is, in some cases, the health plans fully acknowledge they put the pressure on the independent practices, really keeping rates low for the independent high-efficiency providers, often to fund increases for the least efficient providers. And it's interesting to hear that feedback from a health plan standpoint. Of course, hospital employment, rate pressure. We've seen a lot more ASC to HOPD conversions, so same facilities, same nurses, same physicians, different licensure, and that all slows down the industry. On the other hand, we see some real opportunities. The opportunity I just described in spending more time with risk-based entities and health plans. We also see some great opportunities in certain case types, and there's the total joint example is familiar to many of you. We have now 15 facilities doing total joints. We have an incredible value proposition. We can save $20,000, $30,000 per patient relative to a hospital environment for a total joint. Patient experience is terrific. And there's a great demographic tailwind. We have an aging population that tends to want to be really active into their 60s and 70s. And so we have pockets of growth. We see this, of course, also in spine. We see this also in cardiovascular procedures, especially with radial access, really changing the technique to an outpatient basis. So we have these pressures. We also have some real growth opportunities. So there are a variety of different responses that companies in our space have made. And I'm just going to rattle off a few of the biggest ones that have been really interesting because they're highly varied. There are very different interpretations of what to do in this environment of pressure and hospital employment of physicians, et cetera. And so earlier this year, you probably noted that USPI partnered with Tenet with a partial acquisition of USPI, and then over the next few years, an option to buy up the rest of USPI. And so very much a health system-oriented strategy. We've seen AmSurg make headlines with merging with a very large physician staffing company and really diversifying the revenue such that half the revenue now occurs in things like anesthesia and other physician staffing strategies and business models. Surgery Partners has acquired Symbion and Novamed and a real focus around ancillary services. So a very interesting approach and strategy to working with physicians. And then HCA, I think, has been fairly consistent around really buying and building facilities around their hospital footprint. But we've really seen this has been a year of some very notable different strategies, how to respond to these things that we're seeing in the marketplace. So I'll next share how we're looking at it. And I think it was C.S. Lewis that said, what you see and what you hear depends a lot on where you stand. So before telling you what we're thinking and how we're looking at the world, I'll just share a minute about the vantage point from which we speak. So we've got nearly 200 facilities in 36 states that we're investors in and manage. We've added about 100 facilities in the last 5 years, so we've been growing relatively quickly. And you'll see on the logos, there's a real collage both of health system partnerships, and this is something we were very active doing, especially 2, 3, 4, 5 years ago. You'll also see some payers, some insurance plans on here that we're beginning to strategically partner with in a more meaningful way. You'll see some risk-bearing entities. So these are large medical groups that are ACOs or managed capitated risk. We'll talk about this in a few minutes. We think that's really important. And then some very large specialty groups like OrthoCarolina. I think Dr. Murray spoke yesterday, Dr. Dan Murray, a partner of ours. And so I think we've got a number of experiences that have shown us a variety of strategies that can work depending on your market circumstances. Most exciting center that we partner with is that funny-looking state below Florida, which is our medical mission in Honduras. And we actually partner with, and Becky Hines is in the audience, the Holy Family Surgery Center. We have a team of 50 surgeons and nurses there this week. I was there last weekend greeting them, and it is one of the great delights of my role to see our surgeons and nurses provide care for the indigent and just the smiles and the passion. It just makes me proud to be in healthcare and reminds us of why we all got into this in the first place. So if you want to grab me after this and talk about medical mission, I'd be thrilled. So our perspective. Really, the industry, from our perspective, has shifted from mostly standalone entities where having a great surgery center, great outcomes, great physicians was almost always entirely sustainable on its own. Mostly surgery centers over the last 10, 20 years have flown under the radar, quite honestly, with payers. There really weren't ACOs. Many health systems weren't employing. So as an industry, we were largely under the radar. I would argue that's changing. And then, of course, there was a large unaddressed market. That, of course, is changing too. Most surgeons are, of course, affiliated with a surgery center already today. So the question then is, what's the two? From our perspective, there are really 3 forms of strategic partnerships that can be very impactful to a surgery center. Not always, but in many cases, I'd argue most cases, one of these 3 forms of strategic partnership is important. And we'll talk about each of them. One of the structures is to partner with a really large multi-specialty or primary care group, especially these groups that are taking risk. They're becoming an ACO, they're managing Medicare Advantage risk. These groups are becoming a real force, especially where they've organized independently and they have the right contracts and again, are taking risks. So that's one form of partnership. Second one, of course, is health systems. We've talked about that a lot in this room today. We've spent 6, 7 years really exploring this space, and indeed, in many markets, it does make sense. I would argue, though, in many markets, it does not make sense. It really depends on the culture, the strategy of that health system. So we'll talk a little bit about what that can look like when we don't choose that strategy. And then third, perhaps the most shocking, would be truly partnering with health plans. And I didn't think when I started giving this speech 5, 6 years ago here, I'd ever have a bullet up here that would involve partnering with a health plan. But I'll share a little bit of what we're seeing, an actual partnership struck to create clinical networks that reward surgeons for taking cases to the most cost-effective and high-quality setting, and frankly, tipping the scales back towards the independent practice of specialty care, which is an exciting phenomenon. So let me just reiterate, though, these strategies are unique to the market. Healthcare is very local. What works in Chicago may not work in Des Moines. You know this, and that we certainly see this in spades. And so you really need to think about, you have a few options here, and it really depends on the market circumstances as to which one might make sense. So let me first talk about the physician group partnership. And by this, I don't mean syndicating to a group of orthopedic surgeons or ENT physicians. I'm really talking about a large, multi-specialty medical group, especially ones that are taking risk either with Medicare Advantage or as an ACO or some form of capitation. What we see nationally is that the large independent groups are really seeing a resurgence of power and control in their marketplaces where they have remained independent and where they have really gained traction with payers. The data is really interesting, where you incentivize primary care physicians to invest in the chronically ill, those with multiple comorbidities, spend more time with the diabetic, hypertensive, with CHF, perhaps their pre-ESRD. You can really make a meaningful impact. So you see lower ED visits, you see lower inpatient admissions, you actually do see lower surgeries, and modest impact on outpatient visits. And in these models where the primary care physicians or multi-specialty physicians are in a risk-based contract, for every dollar they reduce of healthcare spend, they get that in distributable incentive payments or bonuses. And so you can imagine primary care is 2 or 3% of the total medical spend, but they can impact the other 97% of the spend. Often these bonuses can be a pay increase of 50% or more if they can invest and keep people healthy and out of the hospital and avoid preventable visits to the hospital. Some of the biggest models like this are what Optum is doing, and Optum is a subsidiary of United. Optum has been investing in a number of these groups. The largest group like this is the Monarch Medical Group in Orange County, California, and we'll talk a little bit about Monarch here in a moment. Austin Regional Clinic in Texas is another example. DaVita acquired Healthcare Partners for about $4 billion. Healthcare Partners has a large model like this in Los Angeles, as well as slightly smaller models in Las Vegas, Phoenix, Albuquerque, and areas in Florida. And they just acquired the Everett Clinic, by the way, in the Pacific Northwest. And so these are examples of models where primary care physicians are being paid to not only help keep people out of the hospital environment, but as we'll share in a moment, help direct care to the most cost-effective setting. As you can imagine, we fit in very nicely into that picture. So to go deep on one of these would be Monarch. And again, Monarch was acquired by Optum. It's a Orange County and Southern LA County-based medical group with 2,300 physicians, either in an IPA or employed model. And the bias is towards primary care. They have some specialists, mostly primary care. They have 200,000 lives fully at risk, meaning for every dollar of premium that Blue Cross or Shield takes in, they pass along 90 cents to Monarch and say, here, manage these people, and if you can keep them healthy and out of the hospital, or if you can have a total joint surgery done in a surgery center instead of a hospital, that savings inures to the benefit of the Monarch physicians. And so it's a very powerful model. They were one of the pioneer ACOs, and they actually made it work, and they still are. So they had 6% savings on total medical cost in their first year as an ACO. So we partnered with Monarch about 3.5 years ago. We now have 7 surgery centers, and our intent is to grow it closer to 12 to 15 to cover Orange County and Southern LA. And when we sit down with the leadership of Monarch, the CEO, the chief medical officer, we look at claims data, we look at outcomes. Of course, what they're motivated by are clinical outcomes. They're measured very stringently by a number of the plans in Medicare around outcomes. They're incentivized around patient satisfaction. One thing to keep in mind is if you work with a Medicare Advantage plan, they have star ratings. Star ratings are based largely on the customer experience. It drives a huge part of their revenue. So there's a lot of revenue at risk to have a better patient experience, and that's where the surgery center triple aim really kicks in. They're very motivated around site of service. For surgery, lab, imaging, all sorts of services they want to have occur in the most cost-effective setting, which of course reduces the total cost of care. I think if the CEO of Monarch were here, he would share that surgery optimization is one of the 3, 4, maybe 5 biggest levers they have at their disposal to impact the population's health and cost. And so it's a great example of how we fit into a risk-based model or an ACO. Really, Monarch is just an ACO on steroids. So that's one form of partnership. And there are multiple models like this in groups around the country. There are more than you think there are. And in a lot of cases, health plans and employers are backing independent groups like this to either form, or they're really pitching to try to invest in an independent group that may be right on the tipping point of maybe selling to a hospital system, but maybe staying independent. Those groups are getting courted very heavily to stay independent and go into this kind of model. And that's, I would argue, very good news for all of us in this room. So a second form of partnership is one that's kind of well told at this point. I remember 6, 7 years ago, speaking here, and it sounded a little bit more radical to partner with a health system. And we have actually partnered more than 100 facilities with a health system, so we've got a lot of experience doing it. I would say what's interesting to me, though, is there are just as many circumstances where we decide it doesn't make sense as where we do. The worst thing you could do is, in a knee-jerk kind of immediate way, say, let's partner with a health system. There's a lot of nuance, a lot of judgment. A lot of it has to do with culture, strategy. A lot of it has to do with how much benefit a health system can bring and what their ultimate vision is for independent surgeons and independent facilities in their communities. So you have to be very careful. One partnership that I would, first before doing that, the pressures on health systems I think are well known to you, but it's kind of a tale of two cities. Currently, a lot of health systems have terrific economics, great cash flow, but if you look at the horizon, there are just some terrifying trends that really keep people up at night. The continued shift to outpatient, health plan rate pressure. I don't know if you've heard of reference pricing. This is something that Anthem did in California. It's gotten some modest traction, but the concept's so simple and elegant. We'll pay $30,000 for a total joint, period. If you go to some place that costs more, you as the member owe that money. I'll tell you what, it drives a lot of care to our kind of setting, and so that concept is very much out there. Transparency tools are gaining more and more traction. We use Blue Cross of Illinois to ensure our 8,000 teammates. The transparency tools are getting better and better, and that's really good news. I'm sure you've heard of the prospect of rate neutralization. This is something that MedPAC and OIG have been talking about. And by the way, it doesn't involve raising surgery centers' rates up to hospitals. That's wishful thinking, but it'd be lowering hospitals down to our reimbursement rates. A lot of health systems have seen the rise of these independent medical groups like Monarch, and that's very concerning. And then in the last 2 or 3 months, and this is something Scott Becker and his team would be far more expert on than I, one thing that I found very interesting is the number of whistleblower lawsuits that the federal government has gotten involved with that involve scrutinizing physician employment contracts. And I think it might have been Luke who said here 35, 40 minutes ago, often those contracts are at above market rates, and they may involve a requirement to do surgery in a certain location, that often being an HOPD or a hospital-based environment. What's interesting to see is the federal government is now getting quite focused around scrutinizing those relationships. And the way key TAMs work, or whistleblowers work, is it takes 3 or 4 years to kind of get through the system. So if we're seeing those settlements today, that means it really started 3, 4 years ago. And so that's a concern point, that the employment relationships are getting more scrutinized. So these are some of the headlines, including at the bottom, around some of these settlements around the whistleblower lawsuits around employment relationships. So there are a lot of pressure points on health systems. So to give you a case example around a health system partnership, a partnership that we struck about 4 years ago with THR, which is the largest health system in Dallas, 21 hospitals, one of the largest not-for-profits in the country, about $4 billion in revenue. And what's interesting is the executive team and the board of THR, and this really speaks to you got to have the right culture and you've got to have the right strategic alignment, really said our future is in aligning with surgeons. We don't want to employ. We wouldn't make a good employer, and they would not make good employees. And so our mission, what we really want to do is align. We want a joint venture. We have an express intent to stand up more bundled payments and to stand up more risk-based contracts. We want a lower cost delivery network, and we want these relationships with physicians because at the end of the day, with all the rate pressure and the pressures we're facing, the only way through this is to build our market share, is to have more relationships with more surgeons where we're working with them in the ASC environment And then we have a higher likelihood that when there's a hospital-based surgery, we'd be more likely to win our fair share of those surgeries. And really, that's our way through this tsunami of change in the healthcare system. And it was with that strategic alignment with their CEO and their board that we agreed to craft a market-wide partnership for the Dallas-Fort Worth. They call it a Metroplex, which sounds impressive, and it is, large and growing. So that's an example where it's worked. But I'll also share for every one of these stories, we have at least one, maybe two stories where we've said, this is not right. This is not a partnership we want to engage in long term. And so we've said no to just as many of these partnerships as we've said yes to. And again, a tremendous amount comes down to the strategy and the culture of the leadership and how they really view partnerships with independent community-based surgeons. So the third model, and the last model I'll share, is to partner more strategically with a health plan. And again, as I shared with you earlier, I would not have anticipated saying this speaking here 5 years ago. But if I look at my own calendar over the last 6 months, I've spending the majority of my time with senior leadership at health plans. And 5 years ago would have been the majority of my time with health system leaders. And so it's really an interesting maybe green shoot of potentially a model that will emerge and be more relevant in more and more places. So this is the busiest slide I'm going to share, and I'll ask for your forgiveness here. But this is how a health plan looks at surgery. And so if you start at the left, surgery, as we talked about earlier, is 30% of the total medical spend. If you take that 30% that's on surgery and you break it apart, 2/3 of every dollar spent on surgery is either an outpatient surgery already, or it's an inpatient surgery that really could be done outpatient. So really, I'd call 2/3 of that spend on surgery is outpatient eligible. Then if you take the outpatient eligible, meaning it's either currently outpatient or it's inpatient but could be outpatient, and you break that apart, about 60% of that surgery, or the dollars spent on surgery for outpatient, is occurring in a hospital environment. And really the most obvious savings is for a health plan or an employer or an ACO to shift that care into our environment, where we really live the triple aim and deliver tremendous savings. And this data, this is an amalgam looking at multiple states with the biggest health insurers on their commercial lives. By the way, senior lives, Medicare, looks very similar. You just gross up all the numbers. The per member per month spent on a Medicare beneficiary is about $900 rather than $300. So same ratios, give or take, just the bars are taller, for lack of a better word. So out of that, then, is a question of, well, what can you do? And I'll give you an example of a partnership, one of our two original partnerships in this light that we struck about 1.5 years ago. And it was with a Mountain State Blue Cross Blue Shield plan. And this Blue Cross Blue Shield plan was seeing incredible cost inflation in its community, its employer customers, and never forget, health plans have customers. You have customers. I work for 8,000 surgeons and serve 8,000 teammates. Health plans serve their customers. They wake up and go to sleep thinking about what account did I win, which account did I lose. They celebrate like the Dickens when they win a big account, and they shed tears when they lose one. So their customers were saying, this is outrageous. Our costs are going up 10% a year. You've been telling me about disease management and other programs, but that doesn't make a dent. You have got to do something. And so they were quite motivated, and we had a couple of facilities in the marketplace. And so we proposed to them. We said, look, the issue is an unequal economics, where really the only story that our surgeons are hearing is about employment or about a medical directorship or that pathway. We need to create a credible alternative. And so we jointly created a clinical network where we collect quality outcomes and patient experience outcomes. And we know those outcomes are way better in our settings of care than in the alternatives. And there's an incentive reward for specialists who participate in our clinical network and achieve those outcomes. The net effect of it is to neutralize the economic siren song of employment or migrating to a hospital environment. And indeed, in this community, we've seen about 40% of the orthopedic and neurosurgeons join the network, and a tremendous amount of care has swung to our settings of care. And it has saved Blue Cross millions of dollars. And we quantify this, we measure it, and in fact, we'll often go at risk, saying if we do one of these things and it doesn't save you money, we'll just write you a check. We are so confident this is going to save you money at the end of the day, we'll just write you a check if it doesn't work. But in this case, and frankly in each of these cases where we've done this, it's had a tremendously accretive and positive impact of Blue Cross or the other health plans. Their motivation, of course, quality. I will say they do care about quality. Really cost of care, site of service, and this last bullet point is incredibly important. For a number of health plans, and again, this is not true for all of them, but for a number of them, one of their greatest fears is that the independent practice of medicine, including specialty care, goes away. And that results in great cost inflation. It also really neutralizes the health plan's ability to impact cost. And so one of the explicit hopes in this partnership was to help rejuvenate and secure the independent community. And it's had so far, knock wood, that effect in this community. So that's an example of something that I think, if I had to guess, over the next few years, at least we're going to see more of this kind of activity and spend a decent chunk of our time on it. And where we can get this to work strategically with a health plan can be very, very impactful. So I think I've spoken long enough. Let me wrap up. Some things in our industry, mercifully, have not changed at all. We are absolutely part of the triple aim of healthcare. I'm incredibly proud to be a part of an industry that provides an outstanding experience, great quality, and lower cost. And our industry is changing. And for us, that means these strategic partnership models are more important in more places in order to secure what we do with the triple aim, that to serve our patients sustainably and to keep our practices thriving, we're going to need some new models of partnership. We're needing to be successful with them. And I'll close with a quote that I'm reminded of as the Steve Jobs movie comes out. And I hope you all are going to see it. It looks exciting to me. And it was the talk he gave as CEO, and he said, do you want to sell sugar water for the rest of your life, or do you want to come with me and change the world? And that's maybe a little hyperbole for us, but it's a great honor to be a part of an industry that's on the right side of healthcare, the right side of the triple aim, and to have models that really help independent specialists serve our patients well and be part of the solution. So with that, thank you, and have a great conference.